ever heard about congenital Talipes Equinovarus, CTEV? If not, let us explain more about it.
Did you know Talipes Equinovarus comes from the following? Tali means ankle, pes means foot, equinus means foot pointing down like a horse foot, and varus means deviated towards midline.
CTEV, which is also known as clubfoot, is a common congenital foot abnormality which the foot is pointed downward and inward and associated with soft tissue abnormalities.
Moreover, in clubfoot, the tissues that link the muscles to the bone, which is tendons, are shorter than typical. If left untreated, it can limit a person's mobility by making it difficult and painful to walk.
According to Gibbons and Gray in 2013, CTEV's etiology has not yet been determined. However, there are few risk factors of CTEV reported, such as gender. CTEV is more common in male rather than female in ratio of 2:1. Other than that, environmental factors including having family history with clubfoot and mother smoked cigarettes during pregnancy are linked to CTEV. Broska in 2003 stated that 80% of CTEV cases are idiopathic while the other 20% are associated by other disorders such as spina bifida, cerebral palsy and also arthrogryposis. It is also reported that more cases of CTEV are found in infants who were delivered by breech. There are few possible causes of CTEV including mechanical compression or increased hydraulic pressure in the womb, interruption of fetus development, vascular deficiencies and genetic defects.
The global prevalence of clubfoot is between 0.6 and 1.5 per 1,000 live births. Meanwhile, in Malaysia, the incidence of CTEV is 4.5 per 1,000 live births. The clinical features of CTEV is first, the top of the foot rotates downwards and inwards, the arch is more prominent and the heel is turned inward. The foot may look upside down in severe cases. Calf muscles are commonly underdeveloped. If only one foot is affected, it will normally be significantly shorter than the other, particularly at the heel. When walking, a person with clubfoot normally does not experience any discomfort or pain. If the person is not treated, they may seem to walk on their ankles or the side of their feet.
CTEV may cause impairment in neuromusculoskeletal function, movement-related function, and also muscle strength, and limit some activities including mobility, self-care, domestic life, and social activity. Hence, restrict the participation in self-care, social life, play, leisure, and recreation. These are the factors that contributing to the problems above. We use biomechanical frame of reference (BFOR). It is a remedial approach for choosing on the impairment that disrupt the occupational performance. BFOR use the intervention that address the client factor to improve the occupational performance. In CTEV cases, the OT intervention is to reposition the foot to make them pain-free and have functional mobility. So, BFOR is being used.
First intervention is non-surgical treatment, which is Ponseti method. Ponseti method is the most widely used technique throughout the world. It uses gentle stretching and casting to gradually correct the deformity. Treatment should begin soon after birth. There are two phases of Ponseti method, which are corrective phase and maintenance phase. Corrective phase is manipulation and casting and Achilles tenotomy, while maintenance phase is foot abduction brace. First corrective phase is manipulation and casting. The baby's foot is gently stretched and manipulated into a corrected position and held it in place with a long leg cast from toes to thigh. Each week, this process of stretching, repositioning, and casting is repeated until the foot is largely improved. For most infants, this improvement takes about 6 to 8 weeks. For the Achilles tenotomy, 90% of babies will require a minor procedure to release continued tightness in the Achilles tendon. During this quick procedure called a tenotomy, the doctor will use a very thin instrument to cut the tendon. The cut is very small and does not require stitches. A new cast will be applied to the leg to protect the tendon at its heel. This usually takes about 3 weeks. By the time the cast is removed, the Achilles tendon has regrown to a proper longer length and the clubfoot has been fully corrected. Next is maintenance phase. Even after a successful correction with casting, clubfoot have a natural tendency to recur. Applying a foot abduction brace for a certain period of time can maintain the foot from relapse. The foot abduction brace consists of a bar with open two shoes fastened at the ends in roughly 70 degrees of external rotation. The shoes for the normal foot is placed to the bar in 40 degrees of external rotation in children with only one clubfoot. For the grading, the baby will wear the brace essentially full-time for 23 hours a day for the first 3 months. The doctor will gradually decrease the time in the brace to just overnight and nap time, about 12 to 14 hours per day. Most children will follow this bracing regimen for 3 to 4 years. The goals of Ponseti method is to reduce, if not eliminate, all elements of the clubfoot deformity, hence leaving a feet that are both functional and pain-free, to let kids wear regular shoes and avoid permanent disabilities. Next is evidence-based. The Ponseti technique can repair the deformity in more than 90% of instances of newborn children with idiopathic clubfoot, and as claimed by Radler in 2013, Ponseti method have a better outcome compared to other intervention, and it has become the gold standard for the treatment. The Ponseti approach is a great, easy, successful, minimally invasive and low-cost treatment option for CTEV deformity. Lastly, the Ponseti casting procedure for clubfoot care has been demonstrated to be more successful than standard surgical approaches, giving better outcome with fewer problems.
Okay, now let's move to the second non-surgical treatment for CTEV, which is French method. French method is a process of stimulation of the muscles around the foot and temporary immobilization of the foot by using elastic and non-elastic adhesive tapping. Manipulation of the leg muscles can begin as soon as the baby is born in order to minimize the deformity quickly without causing any foot damage. Okay, let's look at the manipulation procedure of French method. Picture A shows correction of the forefoot adduction and heel varus by releasing the navicular bone progressively from the medial malleolus. Picture B shows derotation of calcaneopedal block by holding the calcaneus bone and stretch it laterally. Picture C shows reduction of talonavicular displacement. Picture D shows manipulation of heel varus. The calcaneus will be rotated laterally from the fibula, while the forefoot is externally rotated. Picture E shows manipulation of Equinovarus by progressively bring the calcaneus from plantar flexion to dorsiflexion while keeping the knee in flexion. Let's look at the second procedure of French method, which is tapping procedure. It is used to maintain the passive ROM that achieved during the manipulation procedure. Okay, picture A to C shows the first of tape that used to prevent the forefoot from turning in. Picture D to E is the tape that used to support the arch and hold the foot everted. Picture F to J shows the tape that been used to maintain the dorsiflexion and eversion. Okay, for the grading, the muscle stimulation and tapping will be done daily for 2 months, then progressively reduced to 3 sessions per week, an additional 6 months. Then, the tapping will be continued until the children can ambulate themselves. The night splint will be used for an additional 2 to 3 years ahead. The goals of French method is to avoid surgery for the children with CTEV. French method is an effective method to correct idiopathic CTEV. Nearly 50% of the infants born with CTEV who use French method shows good outcome of their feet. Next, we move to the last non-surgical treatment for CTEV, which is bracing and splinting. It is an important component for the clubfoot treatment. The compliance to the bracing protocol is the crucial factor of the clubfoot treatment to success. It is the major predictor of relapse in clubfoot rather than the severity of the deformity itself. There are 2 types of brace and splint used for CTEV, which are AFO splint and Witten brace. For AFO splint, it covers both the foot and ankle and only provides dorsiflexion movement. For Witten brace, it can provide some abduction of the foot. The ankle of the brace is in 15-degree plantar flexion and 90-degree dorsiflexion. For the splint wearing regime, the children needs to wear the splint for 23 hours per day for the first 3 months, then they can gradually reduce the time as follows. As the child grows and walking full-time, they still need to wear the splint for 12 to 14 hours per day and maintain wearing it on the night time until they reach age 4 to 5 years old. There are 2 types of surgery for surgical treatment of CTEV, which are less extensive surgery and major reconstructive surgery. For less extensive surgery, it will only target those tendons and joints that are contributing to the deformity. For major reconstructive surgery, it involves extensive release of multiple soft tissue of the foot. Once the correction is achieved, the joint will be stabilized with pin and along leg cuts. So, after 4 to 6 weeks post-surgery, the doctor will remove the pin and cast and then applying a short leg cast which is worn for an additional 4 weeks. After the cast is removed, it is still possible for the foot to try to return to the clubfoot position, so special shoes or braces will be used up to a year or more after the surgery.
So, for a conclusion, clubfoot, also known as congenital Talipes Equinovarus, is a complex congenital deformity of the foot. CTEV is defined as a foot malformation characterized by complex foot malalignment involving soft and bony structures in the hindfoot, midfoot, and forefoot. If left untreated, it can limit a person's mobility by making it difficult and painful to walk. Moreover, the intervention conducted to patients with CTEV are non-surgical treatment, which are Ponseti method, French method, bracing and splinting, and surgical treatment, which are less extensive surgery and major reconstructive surgery.